There we go. Does that look good to you?
It does.
Okay, perfect. Hi, everyone. Welcome to Speak. We're going to wait just one more minute to see if a few more people hop on, and then we'll get started. Hi, everyone. Welcome to Speak. I'm Whitney, the program director at DSP&T. And this month, we're super excited to have Dr. Lina Patel. She is going to be talking to us about managing behaviors in individuals with Down syndrome. So I'm going to hand it over to her. Before we begin, if you'll just please make sure that you're muted, that helps with background noise so we'll be able to hear Dr. Patel. And this will be recorded and sent out if you have to leave early for any reason. All right, take it away.
Perfect. Okay. Whitney, is this screen showing? Okay. Perfect. Awesome. I am so happy to be here. I appreciate you guys giving me the chance to come chat with you about managing challenging behaviors. I am gonna just kind of talk through the presentation, and if you guys want to put questions in the chat or even save them till the end, I'll try to kind of move through the slides fairly quickly so that we make sure that we have time to chat at the end. And I'm sure that you guys have a hard stop today. I'm lucky enough that I kind of created a gap and don't have a hard stop after an hour. So if there's questions that kind of are residual, we can definitely chat about those. I can also provide a copy of the PowerPoint afterwards, Whitney, so that you can send it out to the folks who were able to attend. I think sometimes, listening to the information is great, but it's nice to be able to reference something back and be like, oh yeah, I remember her talking about that. So hopefully that will be helpful as well. So my name is Lina Patel. I'm a psychologist. I work at Children's Hospital Colorado, and I actually have a clinic there that's an affiliate of the C Center for Down Syndrome, where we provide in-person and telehealth to support families with behaviors, toilet training, desensitization to wearing medical equipment, autism diagnoses, working on independence, behaviors, all kinds of things. I also do feeding interventions with another therapist who is specifically a feeding interventionist. And we've been able to do a lot of really amazing work and learn a lot from our folks with Down syndrome. So I am actually affiliated with a couple of different organizations. I like to just share this a little bit. You've probably seen it before, but we're pretty lucky here in Colorado that we have a very big, strong team of people who are doing lots of different things in the Down syndrome community. I mentioned that I am affiliate of the C Center for Down Syndrome over here. And then I work closely with Global Down Syndrome Foundation with like adult healthcare guidelines and, doing some presentations for them and things like that. I actually work at the Cernic Institute for Down Syndrome, doing research in clinical trials for people with Down syndrome. And I specifically kind of head up the part where we're really looking at neurodevelopment and looking at treatment interventions associated to that. And then we're super lucky to have an Alzheimer's and cognition center and an adult Down syndrome clinic in Colorado. So what do I do? I mentioned this already, but I thought it would be helpful to kind of add a couple of other things on here too. Self-advocacy, school consultation. These are all things that I do. Unfortunately, I can only practice in the state of Colorado, but I've never been opposed to answering a question here or there if a family reaches out to me via email, because I have been lucky enough to do this for over, 14 years, which has given me a very large pool of knowledge specific to people with Down syndrome. Still don't know everything, but there are great things that I can share with others as well. So we're going to explore factors that impact behavioral presentation. We're going to learn about proactive strategies to effectively support our children. And we're going to identify the function of the behaviors and how to address them. Okay, so I like to break things down into, separate pieces of things that are like proactive versus reactive. You'll hear me talking about proactive strategies way, way, way more than you'll hear me talk about consequence-based strategies, and I'll explain why. So it's important to know that brains of individuals with Down syndrome are just wired a little bit differently. We know that at or just before birth, the brain of a person with Down syndrome is almost indistinguishable from the brain of an individual without any genetic differences. So I think that this is really fascinating. And I always start when I'm starting to work with families to explain brain development Not because everybody thinks it's super awesome and fun to learn about, but because I think it's so relevant in how we really interpret behaviors and where our kids might have challenges versus where our kids might have strengths. And so it's really important to be able to understand that. The neuropathological differences or the differences in the brain structure that we start seeing, actually, we don't see until about 3 to 5 months of age. And then we see definite difference in by 6 months. This doesn't mean that it impacts the whole brain, but really there are some specific regions of the brain that we're going to talk about that is impacted more than other parts. And then once mature, the brain of a person with Down syndrome, estimated to be about 20% smaller than average, have fewer neurons. And the piece that I think is actually the most significant related to behaviors is that the connections in the brain in specific regions are a little disjointed. So some of the strategies we talk about are going to be very much connected to specifically how the brain processes information and not just some arbitrary, strategies that we've come up with. A lot of the strategies that I'm going to talk to you about are probably ones that you've already used, heard about, or that they're using in other settings that your loved one with Down syndrome is interacting in. But again, the reason why I think it's so important to talk about those strategies is that part of the motivation to implement them is not because someone just said, hey, try this strategy, but really, again, that it's very much grounded in brain development. So, what are the areas of the brain that are affected the most? So, the first part that's affected in difference in volume and circuitry. And when I say circuitry, there's two primary things that I want to point out. So, if you have fewer neurons in the brain, that means that information may have a little bit of a harder time getting from point A to point B. And so, when we're thinking about that, we have to think about how quickly a person actually is able to process information that we give them verbally and then to actually act on whatever that instruction is, right? And so if there's fewer neurons, it just takes a little bit longer or may have a harder time with communicating that information. The secondary thing that actually occurs during that early stage of development is this process called myelination. You don't necessarily have to remember that specific word, but the way that I describe it is kind of going from like dial-up internet to high-speed internet. So each of our neurons in our brain develops this thing called a sheath. And so it conducts electricity much more quickly. That process of developing that sheath on each of the neurons is interrupted in kids with Down syndrome. We don't really necessarily know what causes it. We have some, speculation about what might be the reason for that, but really we don't have like definitive science about why that happens. But what that does is it means that information, when it's being processed in the brain, takes a little longer to fully be able to execute after it's interpreted. So you may have heard people say, "Oh, for a person with Down syndrome, when you give them instructions, give the instructions in a simplistic format, and maybe count to 10 before you repeat the instruction, or you say it differently, or do something else with it." And the reason for that is this process of myelination. If somebody is not acting on an instruction that you give them, there could be more than one reason why they're not. We always make the assumption that kids with Down syndrome, and I don't know if people can see my air quotes because I don't believe this, but people with Down syndrome are stubborn, right? Like stubborn, and it's a personality characteristic, and that's why they're not following through with an expectation or a behavior that we're asking them to do. But this part, what I'm explaining to you about the circuitry and the myelination process, is a huge part of why our kids might not respond as quickly to an instruction as we might want them to. So if I give an instruction and I count to 10 in my head before I repeat it, what I'm actually doing is I'm helping the person to have enough time to process the information that I'm giving them before I blast them with what I call white noise, right? So if I'm going along here and I'm trying to interpret or process information, and then somebody gives me another big old blast of verbal communication, now my brain's like, wait a minute, what am I supposed to be processing, right? And so it actually interrupts the first step of being able to understand what was said the first time. So this process that we're talking about occurs or is a bigger challenge in three parts of the brain. The first part is called the hippocampus. Again, you don't need to necessarily know the names of these things, but it's responsible for memory and learning. Have you ever heard people say people with Down syndrome are visual learners? It's actually kind of a not the greatest way to describe people with Down syndrome because lots of people are visual learners. The reason why we push to use visuals so much with our population is actually because of this hippocampus issue. So for our folks, when they hear auditory information, it's in the brain and they're working on processing it, but they have a hard time, the hippocampus has a hard time holding that information in order to do each of the steps. So say I give somebody a 2 or 3 step direction. If I gave one of you guys that, you may be able to hold all 3 steps in your mind. You execute the first step and then you go, okay, these are the other 2 that I have to do. You execute the second step and then you go, here's the last one I have to do. And then you execute the third step. For people with Down syndrome, because of this hippocampal issue, a lot of times you get the snapshot of the 3 parts of the information, but then you lose parts of that before you actually are able to do it. I've actually seen this happen in when I'm doing like psychometric testing for like school qualification for services and things like that, where I'll give a 2 or 3 step direction intentionally because we're trying to assess this, and the child will do the last step and then have a big smile on their face like they did all of it. And a big part of that is what was the recency of that information that kind of stuck there for a moment in order to execute it, whereas all of those pieces of information did not hold true. That's why we use visuals, is because we want to make sure that somebody has a place to reference in order to come back to it. For you guys, do any of you guys like do to-do lists, right? Like if you have like a bunch of things you have to do that you can't do right in that moment, you do a to-do list, right? That is a visual. That is your way of being able to say, I can't hold all that information in my head to be able to get all of that done today. And I might not even be able to have enough time to get it done. So I make a list and I mark it off as I go so that I know what else I still have left to do. So visuals are not just like the cute little characters and pictures. Visuals are anything that support us not having to hold that information in our memory so that we have a reference tool to be able to go back to. The second part of the brain is called the prefrontal cortex. That's like the CEO of our brain. It's responsible for what we call higher level cognitive tasks. What that really means that it's responsible for planning, organizing, making decisions, problem solving, knowing how to behave in different environments. If any of this is ringing a bell for our kids with Down syndrome, it doesn't mean they're not capable of having the ability to, learn these skills, or inhibition, stopping yourself from doing something impulsive. But it is something that is impacted. So our strategies have to really fold around that to say, how can we help compensate for some of that? So visual schedules, whether they're written or with pictures or whatever, also help with this planning and organization and anticipating what might happen next. One of the biggest behaviors that we see that really taps into this prefrontal cortex part is kids who run from caregivers or wander away. That's inhibition. If I see something, across the street, right? And I'm like, oh, I want to go get that. But then you are able to inhibit that because you can look at the future and go, oh my gosh, there's a lot of traffic. It's not safe. I'm not old enough to be by myself, all these kinds of things, right? But for our loved ones with Down syndrome, again, it doesn't mean that they can't learn that skill, but it requires a lot more overt teaching because that part of the brain is impacted and has a little bit of a bigger challenge to regulate or inhibit an impulse. The third part of the brain is the cerebellum. It's responsible for coordination of movement and learning. There is some evidence for attention and language, but again, these are core things that we need in our day-to-day life to be able to navigate it. And so when we see behaviors, we have to ask ourselves, is it because the person didn't understand the instructions? Is it because they didn't want to do it? Is it because they haven't fully processed the information yet? Because of these areas of the brain that are impacted. Now, as you guys know, not every person with Down syndrome is exactly the same. And so we have to be really mindful of the fact that we use this concept called a probabilistic behavioral phenotype. So what that means is that research shows people with Down syndrome are more likely to show one or more of these characteristics or behaviors but that this does not mean that every child will display these characteristics or behaviors. So we do know scientifically that the vast majority of our kids with Down syndrome will have challenges in these three parts of the brain, but to varying degrees, which is what makes our loved ones with Down syndrome so beautifully unique, in that some may, have strengths in this area while some may have strengths in this area. But that this profile is something that we see a little bit more consistently. So, on top of those neurological differences that I just talked about, our kids actually go through typical changes too. So, think about things like stages of development, right? We do have to think of a developmental approach because we think about, like, when do kids learn communication milestones? When do kids with Down syndrome hit puberty? When do kids with Down syndrome go through the me phase? So what we know is that our kids actually do go through those same types of developmental stages, but that for kids with Down syndrome, it actually happens at a slower rate. So this figure is actually just showing a comparison of language development for a person with Down syndrome versus a child who does not have Down syndrome. Now, important to note, this is, from one study, so it's not like this is true for every single person. But the reason why I like to say this is because if you have somebody who is developing skills a little more slowly, they are apt to have more challenges behaviorally for two primary reasons. So say we think about throwing in very young children with Down syndrome, right? Throwing behaviors. Kids who don't have Down syndrome actually do that as well. It is a very normal throwing food, throwing objects, without actually playing with them. That is not unique to people with Down syndrome. The difference is, though, that when you have a body that is bigger and more capable, right? If I throw something and I'm, a bigger kid, it's going to go farther. It's going to cause more distress. It's going to cause more of a ruckus than if I'm, an infant that's throwing something, right? And so we have to think about it in that context that our kids will hit that stage at a later age chronologically, like so by birthdays, which means their size might be bigger. And then secondarily, the phase tends to last a little longer because it takes longer to develop the skills to kind of overcome that stage of development. And so it is important for us to take that into consideration. And then layer three of why our kids actually are more apt to have some challenging behaviors is because of something called setting events. Setting events, if you guys have ever heard of antecedent behavior consequence, that is one snapshot moment, right? An antecedent is something that happens right before a behavior, then the behavior comes, and then the consequences, like what happens? Does the behavior increase or decrease? So that's a snapshot moment. But as you guys know, our kids are so complex because of their neurodevelopmental differences in the brain that I just talked about, because of their developmental stages lasting longer and perhaps starting at a later chronological age. And then the third part is that our kids have a bigger impact on things that are not directly related, but may impact them, in a different way. So, for example, our kids have communication challenges. That's not going to impact them only in one moment. That's going to impact them throughout the day. Our kids have sleep and health conditions that can, impact, again, behaviors on a whole. Think about thyroid, hyperthyroidism. Think about sleep apnea. Think about celiac disease. All of these things can actually very dramatically impact our kids' behaviors. Or so not sleeping well the night before. All of these things are types of setting events. I'll send you guys this setting events checklist that I probably found like back in 2013 or 2014, but I actually like it better than any of the other ones that I've seen because it kind of gives you an opportunity to highlight what are the things for my personal loved one or the person I work with that really tends to impact their behaviors on a global level. Then when they're in school or when they're at home and people are like, oh my gosh, they had this behavior, it had no trigger, we don't know why it happened, you can say, awesome, there doesn't seem to be a clear trigger in this moment, but what setting event could have contributed to kind of the bigger picture of why this behavior is happening? Say they didn't eat breakfast that morning, or say they had a really horrible night's sleep. Even though that's not happening right before the behavior, it certainly impacts the global ability to regulate. I don't know about you guys. I still actually have my coffee here, still sipping on it at a later point in, in the day. But for a lot of people, if they don't have their coffee, they're shorter, they have a shorter attention span, they're grumpier, they're short with their responses. They have a harder time with like, coordinating kind of what they need to do throughout the day. So though that would be a setting event, right? Not having my coffee or not having a good night's sleep, or say you were coming back from a vacation and your flight was delayed and you were stuck on the airplane. All those things are setting events. So you may not like, have a big meltdown right when the plane doesn't take off, but your fatigue and all of that will impact future behaviors. So this is actually just an example of how I like to tell families to think about, don't just think about antecedent behavior consequence. It is really important for us to be thinking about setting events as well. So this is actually just a tracking sheet for a school where we have identified like what are the primary setting events that are true for this individual. And then we have like the ABC, the typical thing that we see. And then what was the severity of the behavior? And it helps us to then shape how we respond the next time. And if you can see, the summary down below is that it appears that having less than 8 hours of sleep is associated to increase frequency and severity of escape avoidance behavior, which makes sense, right? If you're not getting enough sleep, you are going to be have a harder time navigating your day. So how does this knowledge intersect with behavior? What we know is that there's a higher demand versus the ability to cope because there's, so many other things going on for the person, that our kids are really kind of at a higher chronic state of anxiety or fight or flight because they're not getting all the information. Imagine going through your day and everything is in fast forward, right? You would miss so many pieces of information, right? If you were going through your day and the information was coming at you at that pace. For a lot of our kids, that's true, right? Like they're at school, things are happening very quickly, and they may still be processing, that information at a later point in time because it's taken so long for them to process the information at a pace that is reasonable for them. A lot of times families will ask me like, oh my gosh, should I be concerned that my loved one with Down syndrome does a lot of self-talk? And what we say is self-talk, it can be problematic, but for the vast majority of people with Down syndrome, it's actually a way to process information about what happened during the day at a pace that's reasonable for yourself, right? So not in fast forward. Higher frequency of behaviors due to higher rate of exhaustion of their internal resources. Our kids are more likely to engage in distraction strategies when tasks feel too difficult or unmotivating. There's less motivation to show what you know versus, so show me how you count to 10. Well, why do I need to do that? So we might have more challenges in that respect as well. Our kids are highly rewarded by social attention compared to everything else. So that can be hard to navigate. I will say that this is not true for every single kiddo. Our kiddos who are dually diagnosed, which we won't have time to talk about here, but who do have a secondary diagnosis of autism, maybe social attention is not the highest motivator, but then we work with what is motivating. So really, the bottom line is challenging behaviors is a communication of a mismatch between the child and something in their environment. That's always, to me, step one, is to be able to go, I wonder why that behavior is happening, rather than stop doing that, you get a timeout, don't, do that again. We want to really ask ourselves, put on our detective cap and say like, what is happening in this situation? Is it a setting event? Is it a neurodevelopmental skill deficit that the person doesn't have? And then that's where we get started. So you might be asking yourself, so what? I always think that it's important to say behaviors occur with the context of a situation, but they also occur in the context of neurodevelopment and chronic issues. So if we understand that better, we are going to be so much more prepared to find a meaningful solution versus just putting a Band-Aid on the issue. So this is gonna kind of be like a heavy hitter situation, but I'm gonna go through all of these strategies, and I want you to be thinking about it in the context of the pieces that I've shared, neurodevelopment, setting events, things like that. Now, you will have access to these strategies, and what I will tell you globally is that all of these strategies are absolutely tied to neurodevelopment, to what we know about setting events, all of those things. And so again, my hope is that when you are looking at behaviors with your detective cap on, you're saying, huh, okay, it seems like, Julie didn't understand the instructions, or it seems like I'm, not giving enough information in a short duration of time, or I'm giving too much information in a short duration of time. And so these strategies are going to help us. And I actually call them compensatory strategies because I want people to be able to say, let's implement all of these first proactively, and then let's see whatever is left over behaviorally, right? I guarantee you that if you are really good at or help with implementing these strategies proactively, a lot of the challenging behaviors you see will decrease significantly because we're helping the person to compensate for the things that are hard for them from a neurodevelopmental standpoint. Okay, so you've heard about visual schedules and first then directives, but you may not have heard about what you need to include within those visual schedules. And remember, visual schedules don't mean pictures. You can work with your speech language pathologist to say, what do they understand right now at this age? So some kids may need what we call an object schedule, where you hand them an object and that is what they understand as far as like what comes next or what they need to do. Some kids need photos, and so actual representations. And if you think about as these things get more and more abstract, right? Like cartoon drawings, sometimes schools will use a visual schedule, but they'll say, well, they don't really pay attention to it. And what I would say is that's probably because they don't understand what the pictures are representing. And so that's where those speech language pathologists can be so helpful in being able to say, when I assess them, I really feel like they're developmentally at a stage where photos are going to be much more meaningful for them. We've even creatively come up with things, for some kids. I have a kiddo with Down syndrome and autism that I work with who we have transition songs. So, or songs that are equated to different aspects of the daily schedule at school. So, Ants Go Marching is what they play when they're transitioning from one location to the other. And one of the only things that's super duper motivating for this kiddo right now is music. But now this kiddo has made an association that Ants Go Marching means we're going from one place to the other, right? That's still a schedule. That's still a way of taking something abstract and putting it into a way that receptively our person with Down syndrome understands. So when we think about any type of schedule, the things that we want to include is what we want to help the person to know what they have to do. We want them to know how much they have to do, what shows that they are going to be finished, and what's maybe a preferred or something more motivating that's going to happen next, right? Because the activity in and of itself might not be motivating for this person. But if we can help them go, look, we just got to get through this part that feels hard and get to something that feels better, it's works way better. Here are just some examples. First, then, is like the very basic verbal or visual schedule. First, do this thing you don't want to do, then you can do this thing that you want to do, right? You can verbally use first then directives really broadly. I would say that by 2 to 3 years old, most kiddos with Down syndrome understand first then directives. And it doesn't have to be like, you get a piece of candy, right? It can be just the fun activity that's going to come next. For a lot of our kids, we start with first then directives just to get them used to, being motivated enough to do this little piece before they get to do something they want to. And then we move to things that are a little bit more broad scale. So it might be that we have these schedules that have more activities that they have to do before they get to do the thing that they want to do, right? But we have to build on that. And the reason why I actually like the flexibility of that is because sometimes people have a bad day. We all do. And we naturally, because our executive function skills are more intact in our frontal lobe, we can go, man, today, I didn't get much sleep last night. So I just know that I'm going to have to make my schedule a little less intense today versus a day when I got great sleep, had my coffee, everything went well. Excuse me. And so you'll notice that the second schedule has actually Velcro. That gives us more flexibility to say if somebody's kind of woke up on the wrong side of the bed, maybe we're not going to do as many demands before they get a break that day versus the next day when they're rocking it. This is just another schedule about like, or a visual that supports like, am I doing the behaviors that I need to? Did I use just the right voice? Am I staying in my own bubble? Yes or no, right? And so this here, they would just write like what setting that would happen in. Breaking down tasks into smaller components. Here are just two examples of home schedules that take something really big and break it down into smaller pieces. There's this concept called theory of mind that plays into this. If I'm thinking of a dog, I have one in my head, right? What are the chances that the dog that's in my head is the same exact one that all of you are thinking about? Probably very, very slim, right? Because we look at our environment, I have a dog who you might hear at some point, which I apologize for, but my dog reference is going to be from my experiences, right? And for a lot of people with intellectual disabilities, or even, for our kids with autism or with Down syndrome, they sometimes have a hard time understanding that what I'm thinking about is not the same as what you're thinking about. So say you ask somebody to clean up their room. Every person, some people might say, well, what do you mean by that? Right. But other people might not. And then they might do something thinking they cleaned their room, but they actually didn't. And now I'm going to get mad as the caregiver and go, you didn't clean up your room. But I never actually explained what that meant, right? In my brain, what does cleaning your room look like versus what does it look like in your brain? And so all of these breaking down tasks into smaller pieces is to be able to help a person to know what are all of the little steps that I'm asking you to do versus just the end result, which might not end up happening in the same way that we wanted them to do. So these are just what we call mini schedules to kind of explain how to do these things. Using a multimodal approach for teaching, learn by doing. This is an example of something that's called a prompt hierarchy. So we don't necessarily want our kids to have us do hand over hand or fully help them with things for the rest of their life. Some of our kids might need that level of support for certain activities, but we want to always move towards like what's the most independent we can have them become. So this is just an example of one that we oftentimes will use, where here you're going to say like, I would love to teach the goal of brushing teeth on their own, right? So first I'm going to do an assessment to say like, do I have to do full hand over hand? Do I have to do partial physical prompting? If I model it, will they be able to just do it the same exact way? Am I going to use gestures or a visual? And it becomes less restrictive the more it goes to the left, and more restrictive when it's to the right. I could do a whole presentation on how to help people become more independent that would just be related to this. So we won't have time to go more in depth in that. But again, I'm happy to answer questions at the end. Or if somebody's super duper interested, we can talk offline as well. Turning the abstract into something concrete. Super duper important to understand that people with Down syndrome do sometimes have a hard time with abstract concepts, things like time, right? So when kids are really little, they might be like, are we there yet? Are we there yet? Are we there yet? On repeat, right? We might think in our parent mind, oh my gosh, they're just trying to drive me insane. But the reality is that they don't have a good concept of time. And so when they're asking, are we there yet? It's this need of being like, well, has it been enough time that we can get from point A to point B, right? For individuals with Down syndrome, this actually lasts a little bit longer. And so the abstract concept of time of like, how long do I have to do this thing that's distressing, or how long do I have to do something fun? Our kids may feel like we abruptly interrupted their activity, even if we said there's 5 more minutes. But if I say there's 5 more minutes, but the person doesn't understand what 5 minutes is, then it actually doesn't really help change the behavior or support the behavior, right? So we actually do a lot to make this abstract concept of time more concrete. My favorite one, so here's a couple of examples. I will tell you that lots of my families use digital timers. I'm not a huge fan because I still don't feel like it makes things concrete enough. But if you think about a sand timer, basically when the sand is gone from the top, time is up. So you can see that time it has a progress, right? Like it's making progress. This is one that I've had a lot of people at school use. So you set the timer for a certain amount of time, and then you have like a reminder as well. And so this will turn red when time is up. So it's you know, your typical green, yellow, red stoplight type of system. One of my favorites is this visual timer that's an app on the phone. You can get a free version that has some pop-ups, which is a little annoying, but the reason why I really, really love it is it's a visual image, right? So say I set it for 30 seconds. The in 30 seconds, this image will appear. So the whole thing is covered up, right? In green. And then as time progresses, it reveals the picture. And if I set it for 30 seconds, it still reveals the picture, but within 30 seconds. If I set it for 1 minute, it still reveals the picture, but just within 1 minute. So for a person who has trouble with understanding the concept of time, we can set it for any amount of time. And all that person has to know is when you see the picture fully revealed, that's when time is up. And so we can actually work on increasing and stretching people's ability to wait by using a timer like this as well. Here's another really cool one that we use a lot with kiddos kind of like in the moment. I use it in feeding therapy a ton. So it's kind of like a reverse token system or a token system. The top is a token system where you get a star for each of the, you know, things that you do. So say we're doing 5 bites of food. You know, good job taking a bite, give them a star. Good job taking a bite, give them a star. And then when the all 5 stars are done, you can be all done, right? We've actually done this during feeding therapy with food trials. So I use sticky notes, put 5 sticky notes on the table, and we're basically saying we're going to do, you know, 5 licks of this new food, and then you can be done. After each lick, we'd remove a sticky note so the person can, we can say 4 more, and then you're all done. 3 more, and then you're all done. 2 more, and then you're all done. 1 more. Yay, you're done. So the person is again able to understand the progression of time versus just having to be frustrated and going like, how many licks are you going to make me do? For any of us, when we know specifically how much we have to do, we're going to be much more successful with getting it done. Really, visual overstimulation and understimulation is oftentimes associated with kids with autism. I will argue that is under-researched and understudied in people with Down syndrome, but I find that this actually impacts a lot of our kids. So here are just 2 examples. One of them is in a school setting where they use like a little board when they need to really be able to concentrate, but have the visual information of what they need to be able to do. And then the bottom is noise cancellation headphones. Now, we won't have time to talk about desensitizing kids to wearing noise cancellation headphones. That's a different presentation, but certainly I will tell you that the work that it takes to build up somebody's ability to wear headphones and then the magnitude of the benefit afterwards is super duper helpful. Again, I'll share the slides with you. This little YouTube clip we won't have time to watch, but I think it's a super helpful video clip to show what it feels like to actually experience challenges with sensory issues. And I'll leave it at that so you guys can explore. A pre-specified reinforcer is just what do you have to do in order to get something motivating? And when I say something motivating, again, I don't necessarily mean something tangible. It might be getting a break, listening to music, going for a walk. It might be playing a game with a peer. It can be a lot of different things that are motivating for our kids, but we have to identify ahead of time. So these are some token systems that I've used for various kids. We had a kiddo who loved Minions. And so we have these little Minions, and then this part has Velcro on it. And essentially, you know, if we're working on keeping our hands to ourselves, we might say, you know, after, you know, say typically they can keep their hands to themselves for 5 minutes. So then maybe every 45 seconds, I'm going to give them a token to help them learn the system. And I'm going to say, this minion will go here. Good job keeping your hands to yourself. 4 more. And then we get to go play on the computer. And then, you know, if another 45 seconds goes by, give them another one, another 45 seconds. When they fill this up, then they immediately get access to this. The nice thing about a token system is we may be starting out with 45 seconds, you know, to earn each token, which may make you feel crazy. Like you might be like, oh my gosh, how can I don't have time to do, you know, a token every 45 seconds. But very quickly, once our kids learn the system, you can actually give them a token every 2 minutes, right? So now all of a sudden we have 10 minutes of keeping our hands to ourselves before we get our reward. But our kids are so motivated by this thing that we can keep increasing the time between the tokens, and then the person will still feel motivated to do it. Here's another example of just one that of a kiddo who loved zoo animals, and so we made a zoo animal token system too. I love using things that our kids are motivated by to create these. Preferred item as a distractor. So here's an example. Refusal to transition, flopping on the floor, right? Now, we don't want to reinforce that behavior, but we want to think about, is there something that we could have actually thought about ahead of time in order for the person to not necessarily feel like they are going to flop to the ground? At the grocery store, right? If I don't know how long I have to be there and it's not motivating for me, right? If I can give someone a pre-specified reinforcer by saying, like, I'm going to give you a job, right? And I'm going to ask you to do these things. And then at the end, you can help scan all of the, items at the grocery store. Maybe that's super motivating, right? So the person is able to tolerate the thing that they don't want to do, which is walk around the grocery store to get items. We specify how many items there are, and then they get to scan it, which is their thing that they're motivated by. So we want to tell them ahead of time, we're going to get 5 things, and then you get to scan all of the foods, or you get to swipe the card or whatever it is. Offering an adult-directed choice. Our kids have so many moments where we are dictating what their day looks like. And even as they get older and they want to be more independent, because remember, those developmental milestones still are going to keep happening, but we, maybe because of a skill deficit or a skill that they haven't achieved yet, we might, be giving a lot more, you have to do this, you have to do this. And that's a reason why a lot of times our kids like push back. And if flopping to the ground is the only behavior you feel like empowers you to have a say in something, you're going to do that, right? And so adult directed choices are not choices where it's like, do you want ice cream or broccoli, right? It's not, giving them something that they want. It's, do you want to take 2 bites of broccoli or 3 bites of broccoli? You're still giving a choice, which kind of gives a little bit of empowerment. But the reason it's called an adult directed choice is because the end result is still getting that person to do the thing that you want them to do. I've even used it for toilet training, with kids who have hard time transitioning to the bathroom. Do you want to bear crawl to the bathroom, or do you want to skip to the bathroom? Right? Do you want to walk in front of me, or do you want to walk next to me? It may sound really silly and small, but all of us love to have choices and to feel like we have some say in the situation. You're going to hear me harp on this so much, but I feel like we need to have a curriculum from day one to teach emotion regulation to every single kid on the planet. Um, and I think that for some weird reason, with kids with Down syndrome, we oftentimes even make it less of a critical thing to introduce. And by the time we introduce it, a lot of times our kids are already displaying some pretty significant behaviors. So we're like, oh, we should teach them emotion regulation. When in fact, we probably should have been doing that from the very beginning. So here are just some visual ways of teaching emotion regulation. So you may have heard of kind of like this slow, just right, fast. So your energy level, a lot of occupational therapists will use this. Here's a system that's like, green, yellow, red of like what types of behaviors are green behaviors. Happy, sharing with friends, having a safe body, and then red behaviors, which are mad, screaming, hitting, running away. And we don't want to check in when the kiddo is already escalated, because you guys know how well that goes. What we want to do is maybe have like scheduled times where we check in, right? So every, half hour or hour, we say, hey, what zone are you in? And then we want to reinforce that so that if somebody starts to get into the yellow zone, we're like, oh, we need to find something to help us get back into the green zone, right? And if we can proactively teach that, kids start really asking for that a lot more themselves. For older kids, I really love using the zones of regulation because it takes away this idea that there are good and bad feelings. And it just says these are things that, when we're regulated versus when we're not regulated. And then typically what I'll do is after I teach this to some of our older kids, is that I'll have strategies underneath here of like what they can do in order to get back to baseline, right? So if I'm tired, maybe, and I'm in the blue zone, maybe I need to take a walk or go get a drink of water before so I can re-regulate and be back on task. How many people have ever said, calm down, and it doesn't happen? A big reason for that, again, is that theory of mind piece. What does that even mean, right? What behaviors can I have the person do in order to show me that they're calm before I start trying to re-engage with them? So I love this. This is actually a laminated card that we use, which has like how to show I'm calm. And so it's sitting down, showing safe hands, which is just, intertwining your hands so that they're in your lap, taking deep breaths. And when it says use your words, that doesn't necessarily mean talking, right? Using your words means signing, means pointing, means changing your facial expression. It can be nonverbal or verbal. And so what we do is we have this, I will remove my attention while the person's escalated. I'll hold the visual up. It's laminated. As I observe the behavior happening, like say they sit down, I put a check mark. So I say they now show safe hands, I put a check mark. And then when I've seen all four, then I turn and I say, oh, great job getting calm. Let's figure out how to solve this problem, or what do you need, right? Because when people are escalated, they're not going to be able to tell you what their needs are, especially if they already have challenges with communicating their needs. Telling the child what to do instead of what not to do. You guys heard me mention that your prefrontal cortex, sorry, I'm just looking at the time. Prefrontal cortex is where you problem solve and then find an alternative. That is challenging for our kids. So if we say, don't touch that, don't touch that, don't touch that, our kids actually are like, okay, I won't touch it, but I don't know what else to do. And so what ultimately ends up happening is they keep touching it, right? Keep hitting, keep doing whatever it is. So what we really want to do is we want to really stay focused on what the expected behavior is, or what we want the person to do. And we might say hands to yourself. Great job keeping your hands to yourself. By no means am I saying that all of these strategies are going to work perfectly, because it is embedded within the context of, if I'm touching you and I'm trying to get attention, I might keep touching you, even if you tell me not to, or even if you tell me keep your hands to yourself. So there's a layer to it that we have to also figure out. Using strengths and interests to engage and to reward. I will send this to you guys as well. A colleague of mine that works at the C Center for Down Syndrome and I, many, many, many years ago, were like, our kids are sometimes motivated by things that are not traditional things that kids are motivated by. So we really need to come up with a list that is more tailored to motivators for our kids. What I would encourage all of you guys to do is do a day of observation, right? And in that day of observation, what I want you to do is just sit back and just look at what your kiddos naturally gravitate towards, right? It might be shaking a string. It might be tapping something on their chin, anything that's regulating for them. It might be holding up an instrument really close to their ear. These might not be motivators in the traditional sense, but they are motivators for a lot of our kids. So we want to be able to look at it in a way that's much more specific to our kids. Giving time to process, I hope I don't have to say much more about that, is just really because of the neurodevelopmental profile that I mentioned at the beginning, is that we really need to simplify our instructions, not do a ton of explanation that requires more word processing, and really give time for the person to process what we have instructed them before we repeat it. Huge fan of errorless learning. In our society, we say, let them make the mistake and then they'll learn their lesson. For our kids, unfortunately, I feel like it's a time suck, right? Because what ends up happening is they learn an inappropriate behavior, they create muscle memory for the inappropriate behavior, and now we're expecting them to change their behavior, and it's much more difficult to do. So I always say, can we teach it the right way? Because then what we're doing is we're teaching that person to have the muscle memory to do it the way we want them to, rather than having to undo something first and then teach a new skill. I am a huge fan of something called a visual roadmap. So if our kids have trouble in the prefrontal cortex with anticipating the consequence to a behavior, it's not fair for us to be like, well, you did that and that's why that happened. We want to proactively help our kids to understand what is the natural consequence. Now, this is a generic example. So typically I don't have like this negative outcome, good outcome. Like, what does that even mean for our kids? But for all of you guys, what I want you to think about is we actually put pictures or words for our kids who are reading that show, if I do this, then this will happen. If I do this, then this will happen. And then you let them make a choice, right? So if I this is an example with CPAP. If I practice wearing my CPAP for 30 minutes, then I get to, have time with my iPad. If I don't, then I have to find something else to do, right? But if I'm visually giving agency to that person to be able to make that choice, and it's really kind of a forced choice, then that helps our folks make a decision with agency. You will only see one slide that talks about consequences. And I'm not going to go into a ton of these. I will tell you that I don't feel like timeouts work because that requires a person sitting and thinking about the why their behavior was incorrect. But sometimes our kids are actually doing a behavior that's incorrect. It's not socially appropriate, but they're doing it not for a naughty reason, right? So if I walk up to somebody and pull their hair, right? And then I get put in timeout, somebody's asking me to think about, what you did. Okay, I pulled their hair because I wanted their attention. The problem is not just the pulling hair. It's I don't have a different skill because my communication strategies are so limited to be able to get your attention. So just having the consequence of sitting and thinking about it, the person I guarantee you will come back and say sorry. But did they learn a new skill to replace that old skill with? Probably not. How do we beef up communication? How do we beef up other strategies if they're non-speaking or if they have challenges with sign language? How do I teach them to tap somebody on the shoulder to get their attention? And how do I do all of that proactively? So you'll hear, even with the consequence-based strategies, we are still going to go back to saying, all right, what do we need to do that actually repairs this the next time around? And even if we implement all of these beautiful proactive strategies, we might still have challenges. And so what is important is that behaviors in the immediate moment, that ABC that I talked about, typically have one of four functions. It's either to gain attention, to escape or avoid something you don't want, to get something tangible, or it's a way of internally self stimulating, getting an internal reward from it. So you guys don't need to be, BCBAs or ABA, professionals or anything like that. This is just a tracking sheet that kind of helps us when we're not sure of why a behavior is happening. A lot of times this is what schools will use to track behaviors. I teach families this, which is you are all capable of observing a behavior, identifying what are the possible things that might be causing it, and then what am I going to do about it? So here in this red box, I always have families, and this you can do this even after a behavior happened, right? In the observed behavior, you're going to write what happened in the situation. In these yellow boxes, in each yellow box, you're going to write a reason why you think that might happen. Oh, Joey doesn't have great communication skills. He doesn't know how to get someone's attention. He pulls because he likes the sensation of it or the reaction the other person gives. He pulls their hair because no one's giving him what he wants, right? So we put those each in each of the boxes. Then we say, what if it's this in the green box, what am I going to do about it? If it's this, what's the proactive strategy I'm going to implement? If it's this, what's the proactive strategy I'm going to implement here? And then you go back up to these boxes and you say, what do I think is the most likely reason why that behavior is happening? It might be, oh, they don't have a great strategy for gaining attention because his verbal skills are limited. And so what I'm going to do is now I'm going to proactively practice tap, tap, tapping every time I want to gain someone's attention. In a classroom, what that looks like is before they even walk into the room, the para or the teacher or someone is going to be like, remember, if you want, so-and-so's attention, we're going to tap, tap. You're cueing them ahead of time as they're walking towards, remember, tap, tap. And then the second they do the tapping, we're like, yes. And we ask the child to really give a big reaction, right? Because then that's going to help the person to go, this is what gets the person's attention versus a hair pull or a hair yank. If for some reason we try that strategy and it doesn't work, we don't have to go back to the drawing board completely, right? We might just have the wrong function of the behavior or reason for the behavior. So we look at our other reasons and we say, okay, maybe it's a sensory thing. Okay, if it's a sensory thing, what am I going to do? I'm going to give them that sensory input proactively or in a different way so that hair pulling is not the way they do it. So you really have multiple options of how to solve that issue. When we implement it this way, we are going to be so much better off with getting rid of the behavior. We are not going to be good at getting rid of the behavior if we're not thinking about it from that neurodevelopmental perspective. Here's just an example of hitting self in the head, some examples of what the reason might be, and then you would see that in the green boxes, we would write possible proactive strategies to implement. So here's my last slide, but I will say I love this. I came across this back in 2012, and I still think it's so, so helpful and meaningful in, that was a pun, but unintentional. That it just says the important point is that difficult behaviors do not occur by accident or because someone has a disability. Difficult behaviors are expressions of real and legitimate needs. All behaviors, even if it is self-destructive, is meaningful. Our job is to figure out what the meaning is. And once we do that, oh my gosh, we will see such a huge change in how behaviors present themselves. Okay. I just gave you a lot of information in a very short amount of time. I'm going to stop sharing so I can see your lovely faces. And I would love to answer questions that you might have along the way. I'm just looking in the chat real quick too. Yes, the call is recorded, and I believe Whitney, everyone will have access to it. I will also be sending Whitney a bunch of resources and things that are connected to this presentation. And then have you seen these brain differences, brain development differences in people with Down syndrome who are bilingual and monolingual? Yes, we actually do see it. What I will tell you is that the unfortunate thing is we have much more limited information than I would like. Because we don't we don't have a great way of saying that it should be mandatory that when we do research, we have a more diverse group of participants. So at our team at the Cernic Institute, we have bilingual coordinators and we have folks that can do bilingual, like testing bilingually. But I will say that that is not the case at every single, research place. So a lot of the research is limited by that. I think it would be fascinating to know. We do know that individuals who are bilingual don't have like less of a chance of communication strategies being effective in whichever language possible. We do try to adhere to exposure to whatever the primary mode of communication is, but most of our kids are exposed to both, at least in the United States, being in a classroom setting. Yeah. Hopefully that answered your question. And I apologetically say that because I think that it's a very sad state of affairs that we have not been able to honor a more diverse group of individuals that participate in research, not just from a linguistic standpoint, but also from a sociocultural, socioeconomic status standpoint as well. I will say, if you're interested, we are about to launch this thing called the CDP. The Linda Cernic Institute is one of the sites, and we have a Latin America network. So they are actually collecting biospecimens and also doing neurodevelopmental assessments in Spanish. And we have a whole team of amazing people in South America that we're teaming with. Other questions, concerns, things that didn't make sense or that you want me to expand on?
Hi, my name is Sonia. Let me put myself. Hold on.
Grace?
Oh, there you go. So I'm currently going. I have a daughter. She's 8 years old. She's turning 9 in September. And we're currently going through some behaviors that are new.
Okay.
We haven't had any behavior issues until now.
Okay.
So we moved from Florida to Texas. It's been probably 3 weeks already.
Okay.
And she's showing some behaviors at school that I'm a little bit concerned, and I don't know how to address it.
Mm-hmm.
And I don't know what does the school, if the school have the resources, or
Sure.
you know, it's just I'm clueless right now. So this
Yeah.
what you're doing right now is just so helpful. But I'm just clueless. I don't know how to work with the school
Yep. Yeah.
with what is going on right now. So
And Sonia, remind me your kiddo's age?
8. She's turning 9 in September, so
Okay.
9. Yeah,
Awesome. So she's 9. And are you observing any of these behaviors at home or is it just at school?
that's cool.
Okay. So first and foremost, what I would really, really encourage you to request is for someone to take data. At this point, we're not going to say that you want a behavior plan. That's not, we don't want to implement that yet because a behavior plan is going to be something that follows your kiddo from one place to the other. And our hope is just this abrupt, or not abrupt, but this change and change in environment is just more kind of like having the opportunity to kind of get used to this new system. Um, I would say first, ask them what proactive strategies are you guys using to help help her understand what she needs to be doing, what the routine is, that kind of thing. So really, and then in your mind, you're going to check off like the list because you'll get a copy of the presentation, but just say like, don't tell them, are you using these things? Because a lot of times schools will say, yes, we use all of them, but just say, like,
Mhm.
what strategies are you using? So then you're going to put those on there. And then, or you're going to identify what they're using. And then on the kind of, so that's the proactive part. And then on the reactive part, we want them to start documenting when the behaviors are happening, who they're with, what triggered it. And so they should be able to, if you ask them antecedent behavior consequence, if you ask them to just do some data tracking to better understand like what context the behaviors are occurring, that's going to be the best tool that you can have in order to then come back and be able to go, hey, and I bet you, Sonia, that you might actually go, oh, I totally know why the behavior is happening. Maybe even quicker than the school would be able to identify because you have all this years of experience with your daughter to be able to know like, what things might be triggering. And to me, like those are the two pieces that are going to help kind of create a more successful environment. Once they've collected some data, you can request a meeting to be able to say, like, can we review what you found, so that strategies can be implemented a little more successfully. Does that make sense?
Yeah, a little bit. Yeah.
I'm going to put my email in the chat. For this is for anybody. It's not just for Sonia. Um, but I can also help you write out like what. Just email me and I can kind of write out like what you're requesting for you.
That I really appreciate that. That way I can I'm just gonna let you know what the behaviors are.
Yeah.
Because there's one right now that is just I'm very troubled
Yeah.
about it.
Yeah.
Um
Yeah.
so so yeah.
Yeah. Yeah. And I consult with schools a lot. So I just to be clear, like I see like low level behaviors like, just refusing, flopping and refusing to do work, all the way to kids who disrobe and, run out of the building. Like, so I feel like there's a wide range. So knowing kind of what the behaviors are, and when they're, what the context is of what they're reporting to you, I think is a good starting point.
Okay. All right. Thank you
Yeah.
so much.
Yeah. Other questions? Oh, I see one in times where you cannot control the environment or situations, what is the best way to redirect, regulate emotions? If my son is caught off guard or a situation goes differently than expected, or if he gets very overstimulated, he's very hard to redirect and re-regulate. He can also get aggressive when in this fight or flight mode. He's 9. So perfect. So I would say first things first, planning for worst case scenario. So when you're going into any environment, and I know that this sounds really bad because we don't want to think of our kids as like always being worst case scenario, but I feel like it helps us to feel prepared, right? So when we go into a public setting and we anticipate that it might be a little overstimulating, when we get there, we're going to think about where's a place that we can proactively already have identified that we can go to when we start seeing signs of dysregulation, right? And you know your kiddos' signs of dysregulation better than anybody else. I actually think it's super important to articulate that to everybody that kids interact with, because that's actually going to help our kids to then be able to feel like everyone is going to respond in the same way. The other thing that I would tell you is so environment, like, you may not be able to control the environment, but you can control if you can leave that environment if it's overstimulating. If in that moment he is flopped to the ground already, dysregulated, screaming, crying, or aggressive, typically our kids are only aggressive if we are trying to physically manage them. I'm not saying in all contexts, but I'm saying in that moment, our job when our kids are dysregulated to that degree is to just keep them safe. Can I, create kind of a bubble around the person and just quiet the environment, right? Make sure that people aren't talking, because talking is, oh my gosh, you're asking me to process. I already don't have resources. And now you're giving me another demand, right? So we have to fight our instinct to talk more. We actually have to disengage while still keeping an eye on the situation to make sure that the person is safe. Once the person has calmed themselves, right? Or if I can give them something to calm that I know is calming, sometimes again, something that's a stimmy tool, listening to music, I might just say, first quiet mouth, and then you can have your headphones with music, right? So I'm not saying get up and move and do all the right things in that moment. I'm just saying, show me that you can move towards that calm state. And then that calm state will result in you being able to do something that's going to help you to calm even further, right? So I always think of like, what is the first little thing that I need them to do? Hands to themselves might be all they need to do in order for me to give them, something that's motivating for them. So if you don't have those proactive strategies implemented already, which I highly suggest be step one always when you're going to a new environment, when you're, in a place that you, like you said, that you can't totally control the situation. If you're going to a family friend's house, before you even, before the escalation even happens, what you're going to do is you're going to practice finding a quiet space, and you're going to take your kiddo there to show them if it gets to be too much, this is where we can go. So that even if their instinct is to fight or flight, run, right? That they're going to a place that's still safe. To me, like reducing language, reducing stimuli, external stimuli as much as possible is what needs to happen in order to calm the system. And if it starts to calm a little bit, then adding in other things that are calming to the point where then you can help them to fully calm down. And I will tell you that it doesn't, again, always work that perfectly. We have kiddos who do have some levels of dysregulation that are much more significant than that. And that's where we would need to work with a professional to kind of say, is this something more than just, brief dysregulation associated to Down syndrome? So some of our kids have ADHD, some of our kids have depression, some of our kids have anxiety that's not well managed with, just the supports that we provide. So if it gets to that point, then we do have to seek out some additional supports. Other questions or thoughts? Okay. Whitney, it sounds like we don't have any immediate questions. I hope that this was helpful. I will send some things your way, Whitney, so that you can share with the group. My email address is in the chat. While I cannot provide, I've started to have to do this like disclosure. While I cannot provide direct, clinical care for your loved one, I am never, ever, ever opposed to answering questions based on my experience. And I've probably, over the past 14, 15 years, seen a lot of behaviors that you probably are, wondering about for your kiddo. So I can give you guys generic strategies to kind of start off with if that's the case. So I'm happy to do that.
Thank you so much. This was really amazing and insightful, and we really appreciate it. So thank you.
Thank you guys so much. Have an amazing rest of your day.
Yeah. All right. I'll send out that email to everybody, and yeah, hope y'all have a great weekend.
Bye.